Hello, everyone, and welcome. My name is Julie Shills. I'm the PCPCC Executive Member Liaison to the PCPCC Board. I do this role along with Rob Driven from Merck. I'm currently a Senior Director of Health Innovations at Mathematica. I'm so pleased to be serving as today's facilitator for our webinar on comprehensive medication management. But before I turn it over to our panelists, I have a few announcements. The first announcement is, and I'm very excited to announce this, PCPCC's annual conference titled Key Policies to Elevate Primary Care will be taking place in Washington, D.C. on November 8th. PCPCC has an impressive list of speakers and diverse panels. You'll be hearing from patients. Also, the conference is just 2 days after midterm elections, and there will be an amazing panel of experts to provide some insights based on the outcomes of those midterms. I encourage all of you to go onto the PCPCC conference website, take a look at the agenda, and if you haven't done so already, register. You have the slides, and so you will have all of this information, but the website is www.pcpccevents.com. That night of November 8th, we will also be having the Barbara Starfield Award. This is an inspiring evening recognizing distinguished leaders and innovators in primary care who have helped to shape the field. Always an incredible time honoring a variety of different leaders in the space of primary care. The next day, on Friday, November 9th, PCPCC will host a members-only workshop. This workshop is titled Investing in Primary Care, Advancing the National Strategy. And I just want to point out that as an executive member, and I am one as well, at Mathematica, this is an amazing benefit of membership in PCPCC. So executive members can register when they're registering for the conference. Or on the conference website. And if you have any questions, contact Chris Adamick at PCPCC, and you will see his email address right here. And then last but not least, before we head into what we're here today for, is to remind you that PCPCC released its annual evidence report in August, Advancing Primary Care, a key contributor to successful ACOs. Some amazing information. It really looked at the interplay between ACO and patient-centered medical homes or advanced primary care. So there's lots of resources on the PCPCC website. So now, without further ado, I'll introduce our panelists who will be sharing just a brilliant information with all of you today. First, we have Dr. Amanda Brummel, PharmD. She serves as the Director of Clinical Ambulatory Pharmacy Services at Fairview Health System. What's interesting about our panelists is that all of them have a work in just slightly different organizations, so bring an interesting and varied lens in terms of this work. Fairview is an integrated delivery system. Dr. Brummel has responsibility for clinic development and integration of ambulatory pharmacy services in the Fairview Health System, including comprehensive medication management, which she'll be speaking about today, also transitions of care and outcome quality measurement. Mark Loafman is a family physician who currently serves as the systems chair for the family and community medicine at Cook County Health and Hospitals in Chicago. Dr. Loafman has a leadership focus on primary care practice transformation for vulnerable and underserved populations. That is the population served by Cook County Health, across a network of, a broad network of clinics and the hospital system. Last but not least, we have Dan Rayrauer, who graduated with his PharmD from the University of Minnesota. He's a senior manager of medication therapy management program and the director of managed care residency programs at Health Partners. And Health Partners, you know, Dan is representing an organization that's an integrated health care organization, having both healthcare services, the health plan financing, and administration. So with that, I will turn it over to Mark.
Thank you, Julie, for the great introduction, and thank you, PCPCC, for hosting us. I look forward to this for quite some time. I love the topic. I'm very excited and passionate about it, and my job is just to kind of give you the physician health system perspective on why this topic is so important. And before I turn it over to the real heroes of the talk, which is Amanda and Dan, who know this, they live this work. I promise you, if you haven't heard them, you're going to be ready to go and do this work at an even higher scale than before. My job is really to frame a little bit the opening for this. And I know I'm preaching to the choir, so the PCC and all of you have been early adopters, not only of primary care practice transformation, but even comprehensive medication management, a theme that sort of arose out of the work that you all do. So I really want to just rehash and restate maybe some of the reasons why this is so important, making the case for comprehensive med management, and also to give you kind of a reminder to listen actively with the question, what's holding us back when we have something that has such a powerful ROI that really aligns with practice transformation? What's holding us back? And I say that as an audience member too, because my own health system, we struggle to implement these changes. We're busy fighting fires and working to kind of do today's work today. So think of that in mind and remind ourselves that, across the board nationwide, it's estimated that more than 50% of patients have at least one or more uncontrolled condition that could be managed with medication. And we're going to put aside lifestyle focus. There's an awful lot that can be done. There's a complex and rich set of work and evidence-based work that can happen outside of med management. But the focus today is what we can do right here, this low-hanging fruit of conditions that are responsive to medication. So it's on average half. In some practices have gotten this better. In places like ours with underserved populations and all the social determinants, it's more than half. Less than half of prescriptions are taken as recommended. Devastating them when we have so many conditions that rely on medications that they're not used properly. The old IOM report is the oldest, it's been years now, that $1 of harms costs for every $1 spent on prescription use. And remember, that's simply looking at adverse events. The harm we cause with meds, it's not looking at the harm caused by not treating meds to goal. And we really want to focus on that today. We think all of this has a lot to do with our struggle to find joy and satisfaction in the work. Again, your organization is a prime driver of helping us get out of the business of churning documentation-based E&M visits and getting into practice transformation. But I think some of this comprehensive med management opportunity really gets at where that joy and satisfaction is. And we can't fix the whole health system overnight, the whole primary care system, but we know there's a risk stratified population that's really suffering. They cost a lot, they die young, and it's where an awful lot of health disparities happen, and a lot of, the pathology in the U.S. Healthcare system, what makes us disparate from other populations, and the suffering among the patients that we know. And I've been doing this work 25 years in a similar population in Chicago, and a countless number of patients who suffered, died, who become disabled from conditions that are preventable, complications that shouldn't happen if the system really got them to goal. And so I have on the corner of this slide a little picture that I use a lot. It's kind of that Frank Netterish drawing of a old school primary care doc, wagging his finger or pen, reminding the patient, don't you know? So I've named him Dr. R.U. Compliant because it's that compliance focus that I thought when I first built a network of community health centers that we can get access to patients and have doctors who diagnose and tell patients and educate them what to do, we'd get there, but it's not enough. It's simply not enough. So the primary care system we have, again, preaching to the choir, we struggle and too often fail to halt disease progression. So early disease predictably progresses, often with vasculopathy and neuropathy, high-risk chronic conditions, and we watch people's kidney function fail, we watch their heart function fail, and they get urgently ill. And historically, of course, that was fine. It fed the machine, it fed the system, and now we really understand that's not where the value is. And again, the suffering from patients and this subset of patients who really are at harm's way, who immediately need to get out of the way. How do we move them to a healthier population? Well, you're familiar with this work, I'm sure. The building blocks, it's defined as the 10 building blocks of high-performing primary care. Some of you are in these exemplar practices, I'm guessing, some of the audience. Others of you are striving to be there like we are. But this work really identified 10 building blocks. I've kind of taken the liberty on the work we're doing to hone it down to 8. It seemed to be buckets of work we can do. And I started when I wanted to prepare my thoughts for today to bold the elements of these that comprehensive med management really works with. And I kind of have them all bolded because it fits for them all the way through. As you work down this list, of course, you're working up the hierarchy of the way Bodenheimer and teams have identified these building blocks, but comprehensive med management works. Complements, and I would say it's key to all of them. So getting that patient-centric, team-based, what I call get-to-goal care that our patients need, we would slow that progression, right? We're still going to have patients who are going to progress, but many wouldn't progress. They would slow that down. They'd stay in the early or preventive stages. That's what we want to do. And a big way to do that is getting the medications right. Again, this is a PCC hallmark, so get the meds right. And comprehensive med management is now this predictable, evidence-based set of tools that work. And I think that's what's so exciting about this. To me, many of us have been a member of teams that include pharmacists for most of our career, and we all appreciate having them on standby and being able to get their help. This is a lot more than that. It's a very evidence-based, predictable set of tools to use. And I'm going to use this last slide to really talk about the paradox that I think really makes this work so important and why we need CMM. So, and this really grew, the aha for me and many of us came out about a decade ago when HRSA, the Office of Pharmacy Affairs, got together to launch a collaborative, really focused on safety, on getting medication safe. And as we looked at it, safety, adverse events, again, that dollar of harm that's caused for every dollar spent, it isn't truly a big deal. But the reality is there's even a bigger deal with this lack of effectiveness. So we have safety versus effectiveness kind of competing interests in our primary care world, and we all do this dance every day in our practices. When we focus on safety, it adds more inertia for us to get to goal. We don't push the statin, we don't push the diabetes meds, we don't add to our patients' blood pressure control, etc. We don't think about meds for smoking cessation. There's inertia. We don't want to harm. And that's a good thing. It's a good instinct, but it causes us even more struggle on effectiveness. On the other hand, when I'm getting my quality reports and I'm pushing our practice and our patients to get to goal, I push my meds in a way that cause harm. And so trying to be both safe and effective, that is the job. It's what we need to do. But being both safe and effective in a system that we have today, it doesn't work. It just doesn't work. And I'm really tired of doing this dance in practice. I'm tired of throwing our primary care doctors into this milieu, having them try to walk this fine line to be both safe and effective. And the last, I would say that, when we think of the many places in the health system where we demand and expect safety and efficacy, the so-called high reliable environments, clinical pharmacy is there. And then doing the same elements of comprehensive med management. So whether it's our critical care units, our cancer centers, our HIV programs, our hemophilia programs, the places that get it right, providers wouldn't think about showing up to work without the kind of support we have from our partners in comprehensive med management. So I look ahead to the next slide. It really should help us give that segue. And I think, Allison, you may have the slides back now. So, and there you go. So pharmacists are key members of the patient care team. And I really want to focus on this patient care team. So clearly, obviously, pharmacists are already key members of the healthcare system. But this is an opportunity to have pharmacists a key member of the patient care team. And really, I think once you see this data and the methods that work will be there. So I'm going to turn it over to Amanda and Dan, who are going to kind of dance back and forth about how they do this in their two different health systems to get similar outcomes. And then I'll come back with you at the end and kind of wrap up with some leave-in action steps. So, Amanda?
Thanks, Mark. So as we start to look, sorry, I think we're still trading who's advancing slides here. There we go. I think from a clinic perspective, the other thing that is really evident in practice is the number of measures that are front and center, and Mark talked about that of, getting these quality reports and end up pushing, maybe more harm to our patients by trying to balance all of the different responsibilities and measures that we have. And I know for us as an organization, we have our health plan measures, we have state measures that are coming, there are our own measures, star ratings, MIPS, just really kind of this burden and taunt weighing down on us. And how do we look at that from a team-based approach? And that's really where we have done a lot to incorporate pharmacists into our care team and to provide comprehensive medication management and to focus in on some of these key areas that pharmacists can join with the team to collaborate on. And Dan and I are both going to kind of outline, looking at the quadruple aim, really some of those key areas and the data from each of our organizations on what we have done and been able to show with the incorporation of pharmacists. For some reason I'm there, okay. So first we're going to take a look at the clinical outcomes and what have pharmacists really done to help impact those clinical outcomes. This was a study that we did at Fairview, and really what we were doing is looking at our patients who had diabetes, and we wanted to look at 5 different measures. In Minnesota, we have something called Minnesota Community Measurements, which really looks at the optimal care. There's 5 different outcomes within that, the A1C, LDL at the time, now it's statin use, hypertension, and we looked at all of those 5 and honed in within this work to just around A1C management alone. And we had a year pre having the pharmacist engaged in the team, and our average A1C at goal was 21%, and a year post having pharmacists engaged in the team seeing those patients, we were at 45%. So really, again, utilizing, making sure we were looking at the right populations and taking care of those patients who have diabetes.
Next, sort of going along the same lines, looking at diabetes control, and Amanda mentioned before Minnesota Community Measurement having this optimal diabetes control measure, you can see sort of the components that are listed above that describe sort of how each of those areas is controlled. The results that are showing here are the results of an 8-year program where we worked with a self-insured employer group, looked at a group of their diabetic members, and then we looked at where they started in terms of having optimal diabetes control, and then followed them over this 8-year period where one group had MTM services and the other did not. And you can see, starting off, both groups were right around 16.5%, so very low optimal diabetes control in that population. And this was right around the time that it was really becoming a big deal in the state of Minnesota to work on controlling optimal diabetes. And you can see that in the group that didn't have MTM, there was significant improvements, which we'd expect. Lots of people were working on this measure, team-based care, and there were big improvements made, the optimal diabetes control doubling. But when you look at that MTM group, and I'm using the word MTM and CMM sort of interchangeably, at Health Partners, MTM is sort of a standard industry term, but the practice that we are utilizing is comprehensive medication management, or CMM. So forgive me if you see these differences between MTM and CMM. They aren't synonymous terms, but the way that I'm using them, they are. And you can see here that in that group that was receiving the comprehensive medication management services, we saw a 4-fold increase in optimal diabetes control, and really driven by medication use. So we saw improved use of statins, we saw improved blood sugar control, and improved blood pressure control. Next is looking at something that was a little better controlled, where we had a randomized controlled trial that we performed in our care system. This was to look at usual care versus pharmacist-managed blood pressure telemonitoring. And the results sort of speak for themselves. We quickly saw that really within 3 months, there was a separation between how much control there was of blood pressure in the group that had the telemonitoring component with a pharmacist compared to what was happening under usual control in the clinic. The intervention lasted for 12 months and then was measured out to 18 months after, so gave 6 months worth of time when the intervention didn't continue, and then the results were statistically significant throughout that entire 18-month time period.
So another area that often comes up around medication use, of course, is medication adherence. And so we wanted to take a look at Fairview, those who had received comprehensive medication management, and see if there was any difference in their adherence measures in certain classes. And so you can see here that we looked with statins, ACE, ARBs, and beta blockers. We were able to see an improvement in medication adherence in all those areas. Something that you'll learn as we continue through this webinar, and you may already know through your work with the PCPCC with comprehensive medication management, is we address adherence. It's one of the components that we address when we care for patients. So we, expected to see a difference here, and yet oftentimes adherence is the only thing that is looked at, and we're not looking to make sure we have all of the medications right. So I think it was important to display that, having that full picture, you're going to see these clinical impacts that we're outlining, as well as impacts with adherence as well. The next thing I'll outline is a lot of work being done across systems, right, with transitions of care, and really trying to keep patients out of the hospital and not to readmit within that care. Earlier this year, we published a study looking at our transitions of care program and our comprehensive medication management. So when a patient is being discharged out of the hospital, we actually have some criteria that we used to identify patients who are at a high risk for readmission from pharmacy-related reasons and or conditions that have lots of medications. And our inpatient teams help to flag those patients for us so that we can follow up with them post-discharge. And looking at a 30-day readmissions rate, we were able to reduce that readmission rate 33% in those patients who had comprehensive medication management. And much like Dan was saying, we also have the word MTM in here, and it is because for us it is also synonymous. CMM and MTM really mean the same thing in our system.
Along those same lines, at Health Partners, we also have worked on hospital readmissions. It's obviously a very important concept right now. And from a health plan, we have even more, because we hold the purse strings. It means that much more to us by keeping people out of the hospital. Sometimes hospitals make more money when they have readmissions. In our case, we're trying to reduce readmissions wherever we can. In the population that we looked at, we really went after a very high-risk, high-cost population for our health plan, and that is people who are dual-eligible Medicare, Medicaid individuals. So low income, often facing many cultural language barriers, a very high-risk population where we typically see high readmission rates. And this group is even more high risk in that they were receiving home care services prior to their hospitalization, and were also receiving them afterwards. And what we did is we wanted to know, if we offer home MTM visits to these very high-risk members who are already receiving home care services, can we further reduce their risk for readmission? And we definitely saw that. So by having a plan-based pharmacist go into the homes of patients soon after they were discharged from the hospital, and to work with that home care team as well as their primary care providers, and resolve any of the issues with medication use in that home, we were able to significantly reduce hospitalizations, as you see here.
So hopefully we've been able to outline some of the clinical areas that we have been able to demonstrate that as incorporating a pharmacist with comprehensive medication management in your care team has impacted the overall care of our populations. We also feel it's important to look at the economic impact. So do these pharmacists impact the total cost of care? As many of our value-based contracts are moving in that direction, right? And we have this cost component as well. This was a study that was done with a local insurance company and payer, with Fairview and the College of Pharmacy here, looking at claims for the care of patient population, to look to see overall at their total cost of care to see if any healthcare costs were reduced. Overall, around 31.5% of the costs were reduced. We actually showed in this study that we tend to increase prescription costs, which I think Some were surprised at first, but if you think about it, it's really not surprising. Prescriptions and medications are still one of our #1 things that we can do to combat disease, but it's making sure that they're effectively utilized and managed. What it did show is that a lot of the ED utilization and hospitalizations were reduced. We also looked at this specifically with an employer, a self-insured employer that we worked with, and in their populations, they had patients who were kind of equally matched who received MTM services and those who did not. And for every dollar billed for MTM costs, there was an average in around $9 of savings.
Digging into Health Partners data, one of the things that I want you to know about our organization is that as a result of some of the work that we're showing you, Health Partners has decided to cover comprehensive medication management services across our entire book of business. So we have Medicaid business, we have commercial business, and we have Medicare business. And primarily, the majority of our business is in the commercial market. And so what I'm going to be showing you here is the most recent results of an analysis that we had done on our commercially insured product. So we looked at who was receiving MTM services, CMM services across that commercial book of business. And we matched them 30-to-1 to a national database of that contains other commercially insured members, basically. The result of that analysis showed that we had significant reductions in total cost of care. And similar to what Amanda said, I think unsurprisingly, because we had already sort of thought this through, that medication costs really were not the driver of these reductions. The driver of these reductions in total cost were from reduction of inpatient utilization. We were keeping people healthier and keeping them out of the hospital, and that was reducing their costs, whether or not their medication costs may have gone up. So when we look across the whole population, it was a 20% reduction in total costs, and compared to how much we spent on the program, was around a 3-to-1 return on investment. If we look at the people who were in the top 10% of baseline total costs in that group, we saw a 27% reduction. And typically when we are out targeting people for CMM services, it's that top 10% that we're really going after. Going back to the data that I had showed you a little earlier with that diabetes pilot program, where we had the significant increases in optimal diabetes control over that 8-year period, not unexpectedly, we saw significant reductions in both hospital admissions and ED utilization. And as a result of those reductions, we saw nearly, or that self-insured employer saw nearly $1 million worth of cost savings from those interventions.
So now turning to the patient and provider, looking at more of our humanistic outcomes, do patients and providers find value in CMM services? So from a patient satisfaction standpoint, this is something that we regularly do is survey our patients, and 95% of our patients agreed or strongly agreed that their overall health and well-being had improved because of comprehensive medication management.
We like to show some of the quotes that we receive. I know Amanda and I frequently talk about how great it is when we send out patient survey experiences and we get to see the things that people say back. I think that some of these quotes here highlight a lot of what we see and a big part of what we see over and over again is that people had no idea that a service like this existed, and they weren't quite sure why someone was asking them to go do it. When their doctor says, you should go see a pharmacist, they're kind of a little apprehensive at first because they don't think about a pharmacist doing this type of work. But we see it consistently over and over again that when people sit down and have this very patient-centered experience, they really, really enjoy it.
So looking at a provider perspective, again, this is something that we have been doing for nearly 20 years now within our health system, is having pharmacists integrated into our care teams. And many of our providers don't know life without having a pharmacist. and they really do feel that it helps them to unload their backpack and add to their wellness and to their joy of practice. When we also looked at our providers, we wanted to ensure that they were really confident in the recommendations. And so this is just one of various questions that we asked our providers. And 95% of the providers were confident in the recommendations that the pharmacist was making. Again, showing how they really are integral and seen as a key team member. In our institution, we have a lot of collaborative agreements and others where pharmacists are making a lot of these recommendations directly with the patients, changing therapies, prescribing new medications. And, you know, again, it's really important for us to make sure that those providers are trust in the recommendations that we're making.
So along those same lines again, looking at the quotes that come directly from clinicians in our practices. So you can see, again, from the quote on the top right, that there's a respect and an understanding that the pharmacists are doing a good job with the recommendations that they're making and the changes that they're making. You also see that having a pharmacist involved really helps elevate the practice of that particular clinician that's working with the pharmacist, giving them a little more confidence that there's other people that are competent people that are looking at those medications and really making good decisions on behalf of the patient to improve their outcomes. So now that we've been telling you all of the wonderful things about CMM and how it really affects the quadruple aim, how we are improving health, how we are reducing total costs, how we're providing a great patient experience and improving the experience of the clinician, we now want to tell you exactly what CMM is. So CMM is a term that was created and defined by the PCPCC, which is, you know, why we're here today talking about this. There were many stakeholders from across the continuum who provided input into the definition of what CMM would be. Pharmacy groups, industry, medical groups, nursing, all across the care continuum, people had input into creating this model. And if you look up here, I don't think anyone would be really surprised, especially those of you out there who are clinicians, about sort of the process that we go through. You know, you take a look, you're assessing the medication use of the person, you're looking for problems, you create a plan to fix those problems. The next thing you do is you make sure that what you did to fix those problems is actually working, and you're on that continuum of having ongoing care. Where CMM comes in and where it's different is really its focus around the medications. CMM has the word comprehensive right in its definition, and that's not by accident. When looking at medication use, it's incredibly important to look at all of the medications that a person is taking. So medications meaning prescription drugs, non-prescription, over-the-counter medications, herbals, vitamins, homeopathic, whatever they're doing to sort of, you know, to treat a disease, looking at that as a whole, because every medication a person takes or doesn't take affects those other medications that are in their body. So the pharmacist has a method of going through that assessment and looking to see, is there a reason for every medicine that this person is taking for them to continue taking it? Is there an indication for it? And looking at their chronic conditions, is there a medication that they're not taking that they should be? The next thing they look at is it effective? Is it controlling their condition? Are they reaching their goals of therapy? And if not, why not? The next thing they look at is it safe? Is this medicine causing side effects? Are they using this medicine to treat the side effects of another medicine? Is there some drug interaction or something going on here that makes it unsafe for this particular person to be taking this medicine? And then finally, is it convenient? So a bunch goes into that convenience piece in terms of, can they afford it? Is this the most cost-effective therapy for the person? Do they understand how to take the medicine, and can they actually follow the plan that they have? Is it too complicated for them to remember? The next thing they look at is, does the person understand why they're taking their medicine? And what expectations do they have? Are they expecting to be cured? Or is this something that they know is going to be for the rest of their life? And what concerns do they have? You know, people see the drug commercials on TV. They see the lawyers talking about all the lawsuits that are happening. people are taking those medicines and they see that, and it can cause fear. So it gives them a chance to address those concerns. So a key piece of comprehensive medication management, and again, something that is a subtle but important piece, is this idea of responsibility. And the person who is performing comprehensive medication management is really taking responsibility for that patient's drug-related needs, and they are accountable for the outcomes of the medication use. I know it's a very important part of the comprehensive medication management process to take and accept responsibility for the medication outcomes of the patient that they are treating. And now I'm going to let Amanda sort of talk a little bit more about when people are implementing comprehensive medication management, what allows it to be successful. So now we know what it is. How do you actually move that into practice and have it be successful?
Yeah, so I know we're whetting your appetite, I hope, in many different areas today, and I'm going to kind of reflect on, again, I have a couple of decades of experience in having pharmacists implemented into these care teams, and really tried to boil it down to 4 key pieces that I think is really important, and especially if you are starting out, or if you have a pharmacist, or you are a pharmacist within the clinic, and thinking about, how do I look at this and how do I tackle this? Hopefully, again, we can kind of walk through these steps, and then there are lots of handouts that are available too as a part of this webinar that you can give further taste and information on. So really, number 1 comes down to what Dan just talked about, is having that consistent patient care process or practice model. And I know that it can seem very simple to say, I do this assessment, and I look at these things when I look at drug therapy, and I do a care plan, and I do an evaluation. But oftentimes I think pharmacists can be used as just that information gap person, asking questions, doing a chart review, and that's really not going through and having them necessarily do that full assessment and or follow up on the results of the patient and be able to evaluate if what they actually recommended worked or not. Taking that ownership and responsibility that Dan talked about, again, is key within that practice. It's not enough to make a recommendation and hand that off and not see or hear if that worked well. You really have to be incorporated and to take that ownership and be that team member with the rest of the team on an equal basis that I think is really critical when looking at this comprehensive medication management approach. Number 2 really goes to that role on the team. And what I mean by this too is we each individually, when creating a team, bring certain aspects and strengths that we have that come together, and making sure that as the pharmacist on the team, that they're doing what they do best, that they're actually able to assess that drug therapy, that they're able to make those recommendations. Medication assistance and other things can be a barrier, but we have other team members that can work on those areas too. So making sure that when you're utilizing the pharmacist, you're utilizing them for what only a pharmacist can do. Number 3 is really ensuring that you're looking at appropriate populations and hardwiring that process. When Dan and I talked about the clinical, the economic outcomes, even the humanistic outcomes, it's making sure that we are focusing in on the right populations. You could see the different ROI. So there was still a positive ROI in Dan's 3-to-1 on the general population, but focusing in on that high-risk population showed that 11-to-1 ROI. So again, when resources can be scarce and we're thinking of how do we utilize our resources the best across our population, making sure that you're focusing in on the appropriate population that the pharmacist needs to see, and then again, hardwiring that process. So when I talked about our transitions of care work, we have that alert that triggers in that inpatient hospital stay so that they know who to send those patients to, and it's not a remember game within that, so that can be helpful. And then number 4 is really finding that champion and building relationships. This all does start with, again, that team-based care, becoming a part of the team, having the trust, knowing, again, how to work through some of these things, the role on the team, the appropriate populations, and all of the above goes much smoother if you have a good champion and a great foundation within the team. So those reproducible results, and again, sort of kind of preaching a little bit of the same thing, but when you're thinking of this within your own clinic team and how you can be successful in that, it really does come down to having that consistent practice model. And we have multiple sites. I have about 35 different pharmacists across 45 different locations in our practices, and our patients deserve to have the same level of service no matter where they go. So we've worked really hard at being able to have that consistent practice model, and I think that's allowed us to have reproducible results time and time again because of that consistency in the model. So that's really important. Talking about outcomes, making sure that you understand what your focus is, what are you targeting, and how do you want to measure that in order to show if you're making a difference or not. In our readmissions work, we actually eliminated some of the populations that we were focusing on because we saw that we didn't make a difference or as big of an impact in that population as we did in others. So again, making sure you're upfront thinking about how you're going to measure your results instead of trying to do it in the back end. That critical support from the leadership and the team, and that consistent patient care process again. So you're, again, making sure that you're doing the same work with each patient across the organization. Now I'm going to turn it back over to Mark so he can wrap us up.
Hey, thank you. That was awesome. I love hearing those success stories. And I think what's really exciting is you're bringing kind of the fidelity of the model, you know, when it's done well. And so I think that's vital. And what I wanted to do is just get us ready for a little Q&A time here. So get your questions ready and certainly use the chat box for that too. We'd love to hear from you. But, you know, we're going to get our practices ready for this work a little bit. And I'm looking for this bundle of comprehensive med management to go into primary care. But it's not just the R&R. So the R&R, the refills and recon, and med recon is kind of this basic work we all think of. And we offload that to our staff who are not trained at CMM and unfortunately don't always do it with the fidelity that we're talking about here. So getting that right, I think, is the groundwork that's necessary to begin to take advantage of that work. So I left you with some information there on how to do that. So again, the med recon process, we looked in some of our practices and up to 80% of our RN's precious time is spent, you know, fielding calls and managing faxes and trying to, you know, propose refills for patients. And that really is not a good use of that person's time. And it's not really med management or med recon. And the refill process, either of these things are really opportunities for improvement. So we're looking at optimal ways to make med recon work. And Dan and Amanda did a great job of describing what that is and really looking at adherence. You know, a lot of the pharmacists that we talk to, once they review what we've got patients on, we've been pushing their doses because they're not controlled. And God forbid they take all of those meds because, you know, we've been pushing up their doses because they're not at goal, but they haven't been taking their meds. So it's more complicated than that. This real world adherence is what we have to get at. And then the refill process, something as simple as having a pharmacy home. When we explain to patients the advantage of that, they understand. Don't go to 3 different pharmacies, go to the one, have one that's where their formulary is at. And the idea of refill timing is something that you know, we learned in this process of not using refills as baits to come back. That's a bait to come back, but rather making it a coordinated part of the care process. So having this built into the primary care system allows the clinical pharmacy model to come in and really then add value beyond that. Roll out and ramp up this process. You've heard today about how important it is to use a risk stratified population. Look for those high impact performance measures. When doing that, the ROI is truly reproducible in that model. And then staffing solutions. So many places have looked at pharmacy training programs, bringing that in. Again, you can't throw a rock in most of our settings now without hitting a school of pharmacy. So there's lots of people out there training and bringing them in and teaching them something other than retail. Pharmacy is just a wonderful opportunity to do that. So that is one good solution until you can build the ROI case to be able to hire your own staff, and then expanding the tech roles, getting out of dispensing so pharmacists can practice. And the next slide, Amanda really talks about how we're going to take this forward, so leaving in action. So we really want to think, as you wrap up today, how do we act to deploy CMM in your practice? You know, our patients need us to be disruptive innovators. That's what we're trying to do in our health system. We need to innovate to get the medications right. The next scroll out here says, ask not what's the least disruptive way to stay in compliance. I think we get stuck with that a lot, but rather, how can I partner with pharmacists, payers, and others to move our practice away from churning volume, which is what your whole collaborative is about, to generating life-saving value. So that's the frame. Again, I think Amanda and Dan have shared some really powerful stories of how it works. So really interested in hearing from you, you know, what's holding us back? Why aren't we doing this more robustly and more rapidly? And as you're getting ready to think about your questions, you know, there's a lot of resources out there. The ACTP has funded some really nice work out of the University of North Carolina, and the Alliance for Integrated Med Management. Family medicine's been involved in that, really beginning to get some fidelity around what CMM is. So there's just a lot out there to use and go with. So Julie, I'll turn it back to you and see if we have some dialogue with our participants.
Yeah, some wonderful questions that have been submitted, and as I want to just thank Mark, Dan, and Amanda for your engagement and your thoughtfulness in this presentation. As you spoke, it really reminded me of the shared principles in primary care work that PCPCC has done. And even just yesterday, the National Academy of Medicine put out a position paper on team-based care, and this presentation really aligned with what the National Academy of Medicine was talking about in terms of maximizing all the team members in order to reduce, frankly, provider burnout, as well as impacting quality patient care. So the first question comes from Katie Capps, and Katie asked a question. You know, first of all, she says thank you to Amanda and Dan for talking about your innovative programs. Katie is with, you know, Get the Medications Right, the GTMR Institute, so also working in this area. Any of our panelists, can you tell us what you think the biggest barriers are to getting medications right? And then why is there not broader adoption of this care practice?
You know, from a health system perspective, a physician, I can say, you know, I've been a believer for a decade, and I have a hard time getting it implemented in my safety net systems. And I think, and Dan and Amanda can speak to this too, but in so many ways, the investment comes on the health provider side, and the savings comes on the payer side. And so sometimes it's that disconnect between cause and effect. So I think, you know, that's a big problem. And, you know, there's obviously the workflow and the inertia to change. But we also have, I think, an opportunity, I would say, you know, is to really line up what are the things that the system that would invest in this see value in. And that's what Amanda and Dan, I think, have made an effort to try to share today. These are the things that are not, of course, it's good for the payer. And in many ways, there's alignment there between payer, but you've got to get that connection there. So I would just say, I think that's the barrier and the opportunity.
Mark, just a question before I turn it over to Amanda and Dan is, do you view that, you know, the new and emerging and somewhat older value-based payment models can mitigate that cause and effect that you're describing?
Absolutely. I mean, I think payment reform is at the heart of all this, but you know, even now there's pay for performance measures. There's trying to increase access to care. Even in a fee-for-service model, there are ways to generate billable visits, you know, if nothing else, by partnering with the pharmacist. So, but yes, I think the more we move to value, the better. You know, we want to be ready to have this roll out.
great, and I'll turn it over to you, Amanda.
Yeah, I mean, the only thing that I would add to what Mark said, because I think he's really right on, you know, between this balance of having a clinic or a system support these services, and then, you know, the benefit on the plan side is the value-based change. And I can just speak, again, from our state perspective that, you know, we had early adopters of this work and being able to show the outcomes, and we had our Medicaid payers and others come on board within the state. But really, I would say within the last 3 to 5 years, you've seen almost this tipping point within the health systems that are around here that pretty much there is not a health system that doesn't incorporate pharmacists as a part of their ambulatory teams in this way with comprehensive medication management. And I think as our risk contracts have increased and really just also kind of the culture of having this expectation of having a pharmacist as the part of the team increased, I think that's made a big impact. The other piece that I would add in addition to that, I think from the payer perspective, is they need something that is reproducible and that they can employ across their populations. So it's hard when there's small pockets of this and the service level can be varying for them to really put something in place to be able to pay for it. And, you know, Dan can comment on that as well, but I think now being able to have that reproducible service, to be able to have that consistent patient care process and approach across many different areas has allowed them to be able to put this benefit out for their health plan members in a more meaningful way, which again helps to feed those practices. So it's kind of that chicken and the egg within that.
That's incredibly helpful, and I would add, you know, from a reproducible perspective of payers, you can include employers in that as well, and payers in the broadest sense of the term. Dan, any additional comments you would like to add?
Yeah, I mean, I think Mark and Amanda really hit the nail on the head. The reason that this doesn't exist across the country is because the current economic model doesn't really support it. It takes organizations that are looking to really move head on into value-based contracting and be able to accept the risk that comes with taking on one of those arrangements. And I think that we will continue to see, as Amanda mentioned, in Minnesota, the health systems have all moved in this direction. I think that we'll continue to see that happen with health systems sort of taking the lead and taking that financial risk, knowing that they're going to provide better care to the patients that they are serving. People are going to be healthier, they're going to cost less, and they're going to have a great experience, and everybody benefits from that. It's really about sort of this ugly in-between period we're in, where we have still the vast majority of what we're doing being reimbursed fee-for-service, and how quickly and efficiently do we move towards that value-based care.
Thanks to all of you. I think we have a lot of questions, and I'm already going to tell everyone I'm not going to be able to get to all of them, but you know, you just surfaced fee-for-service, Dan, and I think, you know, many of us understand with the treadmill that fee-for-service causes, and the opportunities in some of the value-based payment models. Is there a path of, you know, the ability, Mark, you indicated that in some ways you can bill fee-for-service, now moving towards a much more comprehensive model and value-based payment. We have some devils in the details questions wondering about, you know, how can that be accomplished? Are there current codes? Is it really a matter of plans paying in your community? So could any of you talk about that?
Great question. I think, you know, when we've looked at this, you can almost break out about 5 different aspects of the business model that can work. So, you know, the simple thing, you know, we think about how many refill visits, you know, kind of go away. Some staff process something with the patient, and we decide, whether we're going to refill them or not, and we write our note about, one more time, and if you don't come in, we're not going to give you any more. So all that work tends to be done, for free on the side. And so, creating a refill management, med management visit with clinical pharmacy that ends up, and again, they shouldn't just be simply managing refills. So there needs to be a triage system so that nursing staff and other staff, so that's why I made an effort of putting this component in there, that, the practice can first get some enhanced competency in managing refills. So these out of medication frantic calls on Friday don't happen. So that's the first step. But when they do happen, it's a cry for help. And then those can become visits that a lot of the clinical work is done. 90% of the clinical work is done. And the physician has an oversight role with that, that becomes a billable visit. And so that's it. And even pharmacy supporting the nursing staff to be able to play that role more. So again, I want to reiterate, I'm not suggesting you put pharmacists in clinics to manage refills, because I think that's a misuse of their time, but to build a competency in refill management so that the handful of patients who really do have clinical pharmacy issues around refills can be seen and by the pharmacist, co-managed by the physician or some provider, and a return workflow that has been given away for free to a much better competency around that workflow that then can be billed fee for service. So that's just one way we're looking at doing it and trying to do some of that in our practices and seeing that work. And then you scale right on up to pay for performance measures, the readmissions practice. So there's the quality measures and the cost savings that are palpable to the system. And again, you can scale it all the way up to full risk value-based payment at the highest level of kind of the fifth level of that. So, and most of us have variations of that in our practice. So we need to be able to do a little bit of all this, just as we are doing with our, primary care in general. We each have a foot in the fee-for-service versus value canoe, and they're getting further apart, and we have to figure that out. So I think this is just bringing that right into that same workflow.
The only thing I would add to what Mark said is there are CPT codes for MTM services. So 99605, 99606, and 99607. They are time-based codes for initial or follow-up visits and the additional time that are needed. I think the acceptance of those across the country is different, but that is the code that we use here. And again, from both our plans and our Medicaid payers, and people can reach out to me if they have other questions around that too. And there's, again, a lot of work that's been done by ACCP that can highlight that as well, but they do exist and are out there to be utilized.
Yeah, I love that. And I think what ACCP has also helped do is to make sure that we don't just get stuck in pharmacists doing churning too. So I think that, right. Amanda's alluding to doing that well, so it doesn't become another, let's just do more billable visits without generating value, but to use that opportunity to generate revenue while also adding value and building your system is key.
This is Julie, and I just want to circle back and thank our panelists for the time they took to share this with us. We have so many questions in the chat room, so I think I'm going to leave this as hopefully we have those questions, and Mark, Amanda, and Dan, I think what would be helpful is to kind of organize them and perhaps be able to, that you've given graciously of your time, but have you look at some of those questions, and then through PCPCC perhaps be able to go back and answer the broader questions. There's a tremendous amount of interest with, which sort of lends itself to potentially having another webinar, but the caliber of the questions that are in the chat room are just too good to leave them there and not circle back. But with that, I want to thank everyone for your attendance, thank our panelists for their experience and expertise, and thank PCPCC for putting on another fantastic, valuable webinar. Thank you all.
Thanks, everyone. Bye-bye.